morning, dear friends. This is the fourth attempt to start our meeting, and we succeed. I suppose that this meeting will not be of any interest if previously we didn't have technical hinders like, out of sound or out of lights. So we are sitting at the 10th International Oncology Forum at a session which is organized and supported by our Association of Medical Specialists on Risk Modification, and it's not happening by chance, because this is the result of our 3 years of effort and experience on the one hand, and on the other hand, this is the assessment of our steps forward that we're going to plan today. And the targets for the future. You have great oncology forum. I always envy my colleagues from St. Petersburg. You have fantastically interesting meeting with great questions on diagnostics, treatment, application of new state-of-the-art, ultra-modern methods of servicing and treating patients with oncology diseases. But we are going to change the vector of this discussion today, and we are going to speak about prevention. We know how to treat. Now let's try to prevent this happening. It's not by chance that the major vectors of the national projects, health and demography, are not only combating oncology diseases. This is a great federal program that allows us to boost the detection rate by 4%, which is absolutely great. In absolute numbers, this is 500,000 of people. This is how we improved our detection rate. But on the other hand, in the national project demography, there is a great federal program, Healthy Way of Life or Healthy Lifestyle. And I would like to say that healthy lifestyle, sticking to healthy lifestyle, will allow us to prevent the development of many chronic infection diseases and also avoid problems related to oncology. Alexey Mikhailovich, in a nutshell, briefly, can you speak about the current situation with the implementation of federal programs? Well, it is exactly the time when the one federal program is almost over, and we are at the moment analyzing our results. And whether it will be continued or not, the main thing is reduction of mortality. And if you look at 5 years ago, when we were just planning everything like re-equipment, specialized service, types of surgery, time of operations. But at the moment, when we have great funding for recruitment of medication, for instance, we understand that we have resolved many things, unprecedented, much better than in those countries that we used to envy once. So, but we need these very costly medications for advanced cancers, and we won't change the prospects if we don't deal with prevention. If in parallel we don't deal with early detection, prevention means, and radical treatment right from the very early stages, further on for the state to economize money in the long run. So that is why we are going to pay great attention to primary and secondary prevention. First of all, it's primary because the healthy way of life is mandatory. A lot of smokers in the country, and all these will result in the oncology diseases, and also the diagnostics. Early detection is still something that is a problem. But this forum is something that is not discussed widely. The topics are multiple, I understand, but still we need to discuss it. And that's why I'm very grateful that we have this discussion here and that we have invited here people who are interested in prevention and combating oncology diseases, as well as lifestyle modification. We have our expert from overseas. When the agenda will be fully exhausted, you will see that the state actually pays great attention to prevention, but we don't know which steps should be made. Like the dispensary follow-up is not sufficient. For example, how do you motivate the decision makers to also modify their lifestyle? How to motivate the employers to be socially responsible and also to modify their employees for healthier lifestyle? So thanks God we have such discussion platforms. And thank you very much, Alexey Mikhailovich. And before I pass the microphone to our foreign guest, who is going to be with us online, I would like to pay more attention to the issues of prevention, preventative screenings, as well as the risk factors, modification, as well as enlarging availability to service, making this more convenient and comfortable. Dear colleagues, we have such a small group of people who are really interested, who are into the issue. What are the risk factors that you know about? But they're universal. They're universal for the CVDs, for endocrinology disorders, and also for the problems related to the field of oncology. What do we need to control in order to achieve our goal? Obesity, smoking, and physical activity or exercise or hyperdynamy, and infections. It's so interesting, it's curious that Russian Federation is not a developing country any longer. So the role of infection is not that drastic in this country anymore. But right from the very start, the seasonal vaccination, like pneumococcal infections, for example, they do work. They help us a lot. I meant Hep B, C. Yes, I quite agree with you. I support this viewpoint absolutely. Okay, let's stop this guessing game and let's remember. Let me remind you that we have 10 main items: nutrition, exercise, weight control, liquids. Intake, arterial pressure or blood pressure, smoking cessation, good sleep, and adaptive stress techniques, anti-stress techniques. From my colleague who has arrhythmia, he has this arrhythmia during the psychotrauma. And as soon as the stress is over, doctors cannot find anything. So we have 10 directions. And who stills, which of them stills the healthy life, healthy years of life? Who sucks the life from our patients? I suppose bosses. No, not bosses. The statistics shows that smoking is the main reason. Millions of lives are stolen by cigarettes. What can we propose to our patients? Apart from just being charming and charismatic, what in fact can we propose to our patients for them to stop smoking? Good word, yes, good word is pleasant to everyone, but this is not the situation that would probably be all. This is a way to hold them within, but it's how to direct them, how to help them. Well, I suppose we should pay less salary or smaller salary to the smokers. That's from the employers. And probably some perks and bonuses and preferences for the non-smoking. I know that our government is already working on this, but we definitely need something like that. Nowhere. It is done nowhere. The best way to work with this risk factor is giving up smoking fully. But when I look in the eyes of my patients and I tell them, dear friend, right from now you stop smoking, what do you think he will change? He will change the doctor to the one who will think and say or propose some convenient alternative. The same happens with the dispensary screenings. Dispensary examinations or screenings, you are just writing something in your phones. I asked questions in different audience. I'd like to ask you a question. Kindly tell me, when does and how does a screening start? With a questionnaire. The lists are already there, and if this questionnaire is something that you will not have to fill in the local clinic, but you will do this in a correspondence mode or from your computer, will it be better? Of course, yes. So you have in the State's service website a questionnaire. We invite you for a screening, occupational examination, and please fill in this questionnaire. I suppose it will be much more convenient than sitting in the local clinic and just filling it on your lap. I suppose people will tell me it's not convenient. Who will find it convenient? And so we are at least fourfold many more, and we shall try that. This is going to be 10, 15% first, but further on, maybe we shall approximate 80%. It will not be, the coverage will not be 100% for sure, but it may be much bigger. There is also quite rich international experience, and rendering this experience, and our next speaker will render this experience. He comes from a faraway Brazil, Professor Alex Peter. Alex, the floor is yours.
Alex, can you hear us?
Good morning, everyone. It's a great pleasure to be with you in this All White Night forums. I'm very proud of being here, of having the opportunity to discuss with you guys about cancer prevention and the formation of cancer alertness among the population, international and Russian experience. I don't speak Russian, then it will be in English. I hope you understand my accent, and let's go. My name is Alexei Peter dos Santos. I am a clinical oncologist in Porto Alegre, Brazil. I work in the private sector here in Brazil, and also I am in the Master of Educational Technology in the University of British Columbia in Vancouver, Canada. I have a long run between my university and my city, my home city. And I'm also president of INTIS and IRAS, that are initiatives about harm reduction, lifestyle medicine, and health teaching and in health technology. There my declaration of conflict of interest, and I don't have any conflict with this presentation. And I will start discussing a little bit about the global cancer risk factors, all ages in the world. And 1 minute, sorry. And as you can see, from 1990 to 2021, smoking is the leader risk factor around the world. And we can see that's a change between 1999 and 21 with things like high body mass index getting more relevance as a risk factor, and glucose is also growing in this scenario. And we can relate this as behavioral risks, but metabolic risks that are associated with behavior. And I think this conversation is always touch the behavioral risks. In Brazil, we see pretty much the same. When you talk about risk factors, smoking is the main risk, but in Brazil we notice that high body mass index is the second, and we can see in our daily practice how people in Brazil are getting obese and how this obesity is responsible for many diseases, like metabolic diseases, like cardiac diseases, heart failure, and strokes, and cancer as well. And here we see the growing of the high fasting plasma glucose with this behavior and metabolic risk about food. When we talk about cancer in Brazil, the incidence is, we have the 5 more prevalent cancers: prostate cancer, breast cancer, colorectal cancer, lung cancer, and stomach cancer. And it's interesting because we see lung cancer as the 4th in incidence in Brazil. This data is from the 2022. However, when we discuss mortality, lung cancer is the leader of mortality in Brazil in both sex. And you can notice that is huge, and sometimes depends on data that we see, the lung cancer is more than the other cancers, the common cancers, together as the mortality. And still there's this huge relation with smoking. How the anti-smoking policy in Brazil works. And we have this program. We are very proud of our policies here in Brazil about reducing tobacco consumption. And we have 3 main measures: include legislation, education and awareness campaigns, and support for smoking cessation. All these data are from our National Cancer Institute, that here we call INCA, and the Ministry of Health of Brazil. Talking about legislation, we have from last century two laws. One that prohibits smoking in enclosed public and private spaces, bans tobacco product advertising mass media, and restrict event sponsorship by tobacco companies. The second law of the last century was the law that sets the standards for tobacco labeling, including health warnings on cigarette packages. In this century, you have these increases. In 2011, increases on taxation on tobacco products and allocates part of the revenue to public health programs, including tobacco, including smoking cessation. Talking about education, we have these mass media programs to raise awareness about the risk of the smoking, such as smoking kills. It's something strong as this, using impactful images on cigarette packs. It's interesting because patients, I deal with lung cancer on daily routine, and my patients with metastatic lung cancer, they still smoke. Many of them still smoke. They can't quit smoking. And there's a huge discussion about these images in cigarette packs. They choose the images because they don't want to see images of smoking pregnancy. They don't want to see images about sexual impotence and smoking, but other kind of figures they don't mind, but they feel more, they avoid some packs, but don't avoid smoking. Our educational program includes the discussion of the dangers of smoking in the schools, in our curricula, in the public educational sector. Our support for smoking is based on our National Tobacco Control Program, coordinated by the INCA, National Cancer Institute, and provides free support for smoke cessation through medicaments in health units, including behavioral therapies and medication. And it's very different between among the country, because it's a continental country, and our public sector is very different in the north and the south. And we are seeing as a whole here, but there's important difference. I have to point out that there's a number we can call. It's call 136, telephone support service for smokers who want to quit. I personally call 136, and what we notice is that there's a lot of diseases that you can discuss there. It's not a specific phone for smoke cessation. It's a phone that we can have news from the ministry. You can have programs about vaccinations. You do have a program for counseling and information about quitting smoking. You can talk to a computer, or you can talk to a person, and it depends on how the lines are busy. It's not a perfect system. In fact, there's a lot of problems here. Talking about data and figures on smoke cessation treatment in Brazil, the prevalence of smoking, we have in 1989, approximately 35% of Brazilian adult population smoked. In 2019, the prevalence dropped to about 10%, according to data from this National Health Survey. This survey is made with landline phone calls, and landline here in Brazil is almost relegate for a third or fourth place. People don't use landlines commonly. We have in Brazil 217 million people, and we have 230 million cell phone lines, but you don't have landlines as comparable with cell phone lines. And then to call and to interview people that has landlines is difficult for us, because it's difficult to understand that the accuracy of data. Myself and my family, for example, we don't have a landline phone in the last 15 years. And then we all use cell phones on a daily basis, and we don't have landlines at home. And then I think there's some bias in this data. However, if we measure the impact, we can say that from 1989 to 2019, we have the decrease of approximately 75% in the number of smokers. And our government says that declining number of smokers is associated with a reduction in mortality of smoking-related diseases, such as lung cancer, cardiovascular diseases, and respiratory diseases. And if you see the forecast for dying of cancer in the next 20 years, we can see that lung cancer is the leader, and it not decreasing. That's for me, it's a conflicting data, because the world and the tobacco numbers say one thing, and here we could say that it's going to be worse if you don't do this kind of thing, but it's not a perfect system. And even though we have a 10%, it's more than 20 million people smoking in Brazil. And how about these e-cigarettes and electronic smoking devices? We have last year a discussion with the public participation. We can send our opinions to the government, and at the end of the day, all these devices, heated tobacco, e-cigarettes, and other products were in the same cat bag, one size fits all. It was the same politician for same policy for every product, and we still have the commercialization, import, and advertising of all types of electronic smoking devices have been prohibited in Brazil since 2009. However, we can see these products every other corner in Brazil because we have access for our neighbor countries, and we have access from the parallel market, and people use a lot of e-cigarettes, although it's prohibited. And there's no regulation that prohibit the consumption, but they prohibit the commercialization, importation, and advertising. And here, just to change our mindset from data from Brazil, and now I'm trying to discuss an opportunity to face this smoking situation. Just a reminder, I deal with patients with lung cancer that suffer with quit smoking and suffering with the failure of having a cancer and still smoke. I think here we can see the equality, and the quality is to divide resources equally with everyone has the same resources. In many situations, it doesn't work well because some people doesn't need the resources. Other will have some benefit, but the resource will be insufficient. When you talk about equity, we talk about the personification, the individualization of the resources, of opportunities, of how to deal with this to get in the goal, to get, for example, here, how to distribute the boxes for everyone to see the game. But our reality, specifically in Brazil, is that some have a lot of resources, much more than they need. Some have the resources in need, and the majority they have no resource at all. And to see that, I will explain for you that 25% of Brazilian population are in the private sector, and I work in the private sector. I can see it by my personal experience. The private sector is a relation between the patient and the physician, choosing regarding the guidelines and regarding the best practice in the world. If something is approved in Europe or in North America, we can use in the Brazilian private sector, 25% of the population, almost 50 million patients. However, 75% of the Brazilian population are in the public market. And this big public market, to more than 175 million patients, we have this more social and political and economical influence of the guideline. Once there is a medication, we have this relationship with implementation in this sector and the policies that influence this sector. The power is not on the guidelines, but the power to implement the guidelines is influenced by ideologies, values, power, relationship of interests and of different actors, financial motivation, economic theories, ease of political implementations, fashions, elections, and many other factors. At the end of the day, there's a gap between the science and the implementation, and we can prove in at least 3 or 4 clinical trials in Brazil that implementation, that lack of implementation, in fact, kills people. We can show it in lung cancer, you can show it in breast cancer, showing that the lack of medication and the lack of technology is responsible for this increase of mortality in the different systems. For me, a solution basically discussing about tobacco and any other addictions that we can discuss pass necessarily for harm reduction concept. This is from Goldstein in 1994, Addiction from Biology to Drug Policy. And the concept of risk or harm reduction is essentially minimizing the damage addicts do to themselves and others, while at the same time balancing human treatments of addicts and respect their human rights against the rights of other members of society. When you ban smoking from private places, we are discussing this. If the person wants to smoke, not to smoke in front of other people and to prejudice and to have some harm or damage for others. And it was the first concept. It was really thinking about drug addiction, and we can understand at that time that physicians recognize that some diseases can neither be eradicated nor cured. They simply do the best they can do to reduce the harm, acknowledging and accepting it's not every problem that has a totally satisfactory solution. We are oncologists, we know that we work with metastatic diseases where we balance the risks and we balance the toxicity of the treatment, the toxicity of not treating the patient, the pain related with disease, the disease symptoms, the treatment symptoms. And then for us, I think harm reduction is in our routine, is in our mindset. But I notice here in Brazil that for all other specialties, this concept is not so clear. A modern concept, and for 2017, tells us that harm reduction refers to interventions aimed at reducing the negative effects of health behaviors without necessarily extinguishing the problematic health behaviors completely or permanently. This connects with nicotine, this connects with food, this connects with alcohol, this connects with everything in medicine. We can discuss. If we will not prescribe a soda, we can tell which soda is better for that situation. Although for us, it's better for patient to drink water. I'm having some water here. This ASCO meeting, Sunday morning, June the 2nd, I was there to watch the place of e-cigarettes in smoke cessation treatment and policy approach from around the world. My expectation was to see a lot of countries showing their initiatives and discussing and showing their challenges. But in fact, it was a discussion of some policies in England, the United States, Australia, and New Zealand. And I can tell that 3 things were clearly for me there. They were important to discuss. One is that e-cigarettes and harm reduction have helped in England 30,000 to 50,000 each year to quit smoking since 2013. We have more information about that in a Nature publication, Nature paper. Nicotine in cigarettes is a tool for smoke cessation. And they discuss a lot of these traits and these characteristics of these implementation policies around the world. But one big concern is the risk of new smokers and the risk of adolescents to get in the smoking scene versus the subset of adults that are already smokers and they have the need, the bridge to stop smoking once they already try it to quit smoking and don't get the goal, and how these tools like e-cigarettes can help them in this proposal. The necessity of mixed policies, the necessity of discussion, and to understand that we have a lot of products for in the bag of e-cigarettes. To understand that some of them they are flavors like watermelon. A smoker doesn't want to taste something with watermelon. This is for for adolescents, for new incomers. This is not, in my opinion, this is not what you want. I see here one more tool to help us in this process of quitting smoking. And the risk of advertising, how to advertise that, how to see that, for me, we can use as a medication, but it's not clear in the literature, it's not clear in many countries. In Brazil, we have the impediment of
Dear
this.
Professor,
And
Dear Professor, I'm terribly sorry, I have to remind you all the time. We have a requirement.
I think I am in the end. Yeah. I'm sorry about that. And the solution is about education. I think here we have this process of from our comfort zone, from where we are now, and the pain to change, to stop smoking, for example. We can cross the situation. And here I want to remember two concepts. One is what is cultural competence. It's to learn about other cultures, control your biases, and adapt your behaviors and communication style considering the background of people around you. Cultural competence is an ideal. What is cultural humility? Being aware of the power imbalances and differences and respecting other values, culture, race, ethnicity, nationality. It's a mindset. We have to be able to communicate with our patients and to accept their situation and to deal with these challenges with them, okay? And to do this kind of thing, in my ecosystem, I connect, this is INTES, that I am president. We connect with Latin American Lifestyle Medicine Association and African Global Health Reduction, that is an educational program in Caribbean and Central America. REDACA, that is a group of study of harm reduction and lifestyle medicine. And we form this International Alliance for harm reduction, and together we are promoting the first IRIS International Symposium about harm and risk reduction, lifestyle medicine, and connecting patients to governments. It will be next November in São Paulo, and you are all invited. We use evidence-based actionable clinical guidelines to make decisions that support a healthier future. It's important to show the government the needs of our patients. Thank you so much, and sorry about time.
Thank you very much, dear Professor. Thank you for the invitation. Ну, а мы продолжаем нашу сегодняшнюю программу, и я попрошу профессора.
We are going to continue with our agenda. Now I invite Professor Eminitov to speak not about the faraway Brazil or the global issues, but to speak about the country we live in, Russia. So when we speak about struggling over any diseases, oncology being part of them, there are several aspects to that. First, it's prevention. As a matter of fact, when we speak about prevention, we need to get rid of the factors that bring about disease. Very frequently, that's early diagnostics that would help us. There are also such concepts as treatment, rehabilitation, and also observation or follow-up, dispensary follow-up. But here we have features and petty details. Indeed, if you look at how our mankind lives nowadays and in the recent 100 years, there are a great deal of differences and discrepancies if compared to the previous story and history of mankind. It's exotic lifestyle. Yes, indeed. Recently, about 100 years ago, the mean lifespan was 50 years. Then antibiotics appeared, also methods of combating CVDs, pressure control, heart failure methods, and approximately the lifespan has grown 1.5, even almost twofold. But the evolution actually cannot be tricked. Human beings have different resources. Just come to think about it. The famine in Europe were in the 50s of the previous century, mid-20th century. The fact that 2 billion people actually eat when they want, it's exotics. It has never been like this in the history of mankind. Who in the animal world, the evolutionary, the victory is belongs to those animals who can eat more. And with the pets, for example, they eat more than they need. The same happens with the human being, because this is evolutionary mechanism. We need to have stock of fat. Then birth control. Well, the mankind actually had never had any control of fertility. And so there is no breast cancer. It was just a disease of the nuns. And at the moment, it's widespread, and there are no real prospects for the reduction of this. It will be like this. There are also airplanes. A white person can go to Egypt and lie under the sun in Egypt, for example, but the other side of the coin is melanoma. Yes, it is quite exotic, and smoking is quite exotic as well, and I will talk about it a bit later. So it's not just food that is available, but also the calories are different, because the thermal processing is something relatively new. Subsequently, people instinctively eat more than they need. They eat what is easier to digest and to eat, so these calories intake would be different in Europe and in Asia. And again, it's very dangerous. So, obesity and cancer. The fact that obesity is the major reason of a shorter lifespan in this century, this is something that we recognize today. Even if you look at the oncology diseases, we usually say that smoking is the worst. But smoking cessation does happen. In the developed countries, I would say that the biggest problem is small obesity. This is the reason for breast cancer, colorectal cancer, and prostate cancer. I would say these are the major bulk of the morbidity in oncology. Just imagine that all of us are keep food under control. We shall have twofold reduction of prevalence or incidence of each of these cancers. We should understand that raising awareness is utterly important. We consider that dairy products are good but generally speaking, it's nonsense, because milk is for newborns. It's not for grown-ups. This is not something that you should take daily. than the change of behavioral stereotypes, because you need to eat to feel full. You should actually convince people, but pharmacological correction is required, like metformin, for example, that normalizes metabolism, and definitely some pills will exist. Just propaganda will not be sufficient. And also, like, excise for fizzy drinks, sweet fizzy drinks, and this is a new duty. And I consider that not every country has actually imposed such a duty tax, and that we can, in a couple of years, compare our results. Now, smoking is quite exotic because these are thin pipes that have small tobacco leaves, which are accessible for inhalation. They appeared just 100 years ago when the process of their production became automated. So yes, indeed, there was smoking, but there was no mechanism of effective delivery of tobacco and nicotine. And just an addiction appeared just 100 years ago. Now there is an interesting story. The fact that smoking is the major reason of lung cancer was proven only in the end of the 50s. And in the 60s, as soon as the medical authorities started claiming it everywhere, both in America and in Europe, the number of smokers has been reduced by threefold. But further on, this trajectory was violated, because further on the commercializing was banned and the prices soared, and there were alarms on the packs. Yes, the number of smokers, they go down, but because of different factors. I will come back to this. So, in fact, we have deeper, hidden factors that are the basis to this process. In my country, it's quite civilized. Our country follows all these restrictions for the tobacco production. For example, it's banned to smoke in the medical settings. Also, there are many other bans which are imposed, and Russia here is actually at the same level with other developed countries of the world. But there is always a but people smoke for nicotine. It's an adaptogen. Can you show me some other pharmacological substance which, at the one hand, allows you to concentrate and also gets rid of anxiety? No. Caffeine, you have excitation. It doesn't comfort you. Nicotine at the same time comforts and allows you to communicate and concentrate your attention. So, generally speaking, there is a psychological, so to say, addiction, which is just behavioral. But at the same time, there is a physiological and biochemical addiction as well. And here comes an interesting aspect. Back in the 60s, when they started combating smoking, the most informative was Germany. And 70% of whether the person smokes or not depends on genetics. Of course, epigenetics and the environment plays a great role. It can be just available only for men, for women, or there are equality in some countries, gender equality, but 60-70% inside the community, still a decisive factor will be genetics. And here it's quite clear. How does nicotine work? It releases dopamine, and dopamine is a substance that stimulates the pleasure center when you feel comfortable, everything is all right, and you feel good. So nicotine allows you, just stimulates the basal activity of this. We have decided to have a much more refined approach. There are people who have never tried smoking. They don't actually know whether they will be addicted or not. And these people who have never tried to smoke, actually, the person who is not prone to any risk and search for novelty. There are also people who tried to smoke, actually, but they didn't become addicted. They don't have addiction. Also, there are people who are addicted. They can be also fall into two categories. Somebody managed to give it up and others not. So the genetic constitution, so to say, is the structure of genes that are part in the dopamine metabolism. So they would impact the reward center, and they would definitely determine whether you will become addicted or not. Apart from the social factors, the role of genetics is quite evident. And hence, we have another conclusion. We can ban tobacco. We can ban nicotine-containing products. It's quite realistic. But some proportion, approximately 1/4 of people, will feel discomfortable. They will feel discomfort, and they will be looking for other stimulation of dopamine receptors for reward center stimulation. Alcohol, drugs, this is the same reward center. And what is good and what is bad here, that's disputable. So the question about safe delivery of nicotine is quite an actual discussion. That is something that requires serious discussion. So it's when there is a combustion of tobacco, and then there is cancerogen that is released. And there are some other ways of delivery. For example, they do not consider cancerogens like e-cigarette or a patch. Of course, from the social stereotypes, e-cigarette would look like a cigarette, and these products also have some social segment. On the one hand, we should understand that there are two technologies: electronic system of warming, when the tobacco is warmed, but there is no combustion, there is no burning process. And there are also aerosols with different aromas which contain nicotine. This is not a natural product. And here we have something similar to the cigarette, when it is a short period ritual, some dose. And here we have the liquid, the fluid form, when a person can do this. There is no dosing here, and that's dangerous. In the developed countries, this product is regulated because more or less what is released by a big company has been piloted and medically validated. But what is bad about it? In many countries, there are a lot of, so to say, fake products. When something alike is produced, like a nicotine aerosol, but there is no validation, no checks, and everything that is used by a human being, they must be tested in terms of harm. There must be certification at the level of the product, and that's a big problem. Because, of course, they are validated. The validated products are much more costly than non-validated ones. And here we have a heated discussion. We consider that in the contemporary society, many people would like to have these products, but the question is in the harm extent or harm degree. There are two approaches. Negation, no nicotine, no addiction. This is something that we have in traditional smoking, and there are also attempts to find compromise. When we consider that the harm from cancerogens from smoke should be got rid of, but the nicotine actually, if it is delivered in a different way, can be harmless, or at least less harmful. And this is something that we have recently, until very recently, we have ignored it. What's interesting, I had an opportunity to also compare these results on the genetics of smoking in a psychiatrist congress in Tokyo. And what I paid attention to in Tokyo at this congress, in countries where there is pragmatic approach to the risk reduction, where they stimulate the smokeless delivery methods to push out traditional smoking, then the traditional smoking goes down markedly because people have alternative. Thank you for your attention. Thank you very much, Evgeny. But I have a feeling that my question to the floor, in fact, is not even needed. what are the opportunities of risk reduction? What are the barriers? Okay, I will rephrase it. So the barriers are quite significant, although we are human beings, but nonetheless we consider that we should go along the pathway of negation, just banning everything, zero tolerance. But at the moment, we're in a very difficult phase, because when we speak about the harm of nicotine-containing products, it's a question to academia, to the scientists, not to the propaganda. And hence, we have a lot of conclusions. For example, we have ban overselling this product to children. But when I was a child, I was banned to drink coffee. It's quite disputable now. We had Sicorium, I remember. Yes, but, well, this is a search of something reasonable, of where the truth is. It's a huge barrier by itself. Because generally speaking, just come to think about it, a person usually is convinced that it should be either zero tolerance or it should be allowed. What do you think, people in the room, in the floor? What are the barriers that you see? What is the hinder of implementing this harm reduction to the wide practice of healthcare and social life? And in fact, up to now, it was zero tolerance and policy, and all of a sudden, you can smoke but reduce harm. It feels as if you just kill everything that you have done previously, and you are looked at as if you are promoting smoking. No, not at all. Yes, but it should be considered at the level of the state. And again, we should consider and reconsider things. Well, like this. Any substance can be either harmful or not. So can we drink or not? Should we drink alcohol? The same with smoking. Well, I can give you an example, something that is not very relevant to this topic. In the United States, for example, there are separate states where marijuana, for example, is quite legalized. So there are opinions, and there is a barrier of just beliefs. It's good that we have beliefs and opinions, but I suppose that if you are wise enough, if you are reasonable enough, you reconsider your beliefs from time to time. Alexander, also from our young colleagues from R&D Center named after Petrov, there is a question to the Brazilian author, to the Brazilian colleague.
Interesting and informative presentation. I'm a clinical resident in medical oncology with the National Research Center of Petrov, and I have a question for you. When you collect anamnesis data, when you assess your patients, do you differentiate between the different types of nicotine-containing products, or do you just answer the general question of whether the patient smokes or not?
Thank you for your question. It's a very challenging question, and nowadays, as the guideline, our guidelines is if you smoke, do not smoke, and I don't want to know what kind of smoke do you have. This is a kind of official answer. I never do this kind of thing. I try to understand the motivations and if the patient had already tried and what kind of product he's using. Remembering that another e-cigarettes or anything besides cigarettes are banned in Brazil, are not allowed in Brazil, but we're facing on daily routine. And if I can discuss this and show that even these products, these new products, they have risks, I try to stop the use. But I think when I face a patient that's not smoking cigarettes, that is smoking another product, using another product, I think that's there's a person that already think differently you know, and I think this is an opportunity. I myself, I never prescribe anything like a new form of nicotine approach or a e-cigarette because I'm not allowed. I use nicotine replacements. I use bupropion. I can use varenicline in my routine for my private patients, but I try to understand and to discuss this kind of thing because our goal, our deal is zero tobacco, zero any kind of tobacco. But I think it's different to discuss about cigarettes and about new products, and I have to understand what was the motivation, because the patient used cigarettes and tried to bridge with e-cigarettes. Is this the option? Or, on the other hand, it was someone that, no, I'm using e-cigarettes because it was safer and I don't want to smoke, but I am a never smoker. Oh, it's different. I don't approve this kind of posture, and I face this with kids, with teenagers, even in my family, because in schools here they think it's fancy, the e-cigarettes and some vapes, and we are discussing this, that is not safe. We don't want new nicotine addicts at all, although we know that people will be addicted to nicotine independently of the politics, the policies.
Alexei, thank you very much. Thank you very much.
Спасибо большое. Thank you. And I'm closing our meeting, and I'd like to stress it once again, and you are quite right. This is not a step back. This is evolution. It's development. Because we have had a ban, we have had 80% of smoking cessation, but then we stopped. And in order to move forward, we need smarter solutions, which will be available for the patients, for the regulator, for the doctors. And only then, if we have this smart solution, then it will be a success story. Thank you.
Уважаемые коллеги, хочу анонсировать еще одно важное мероприятие.
Now, I would like to announce another event. In the press center, there will be a signing ceremony of the memorandum between the medical specialist on risk notification and St. Petersburg R&D Oncology Center named after Petrov. Red 8. I will be happy to see you.